welcome officially to the Advocacy Exchange. I am David Craig, CEO of Grit Health, and we are the partners to Bristol Myers Squibb in bringing this Advocacy Exchange platform to life. Today is a really special moment. Not only is it the last live session of 2021, it is also our 28th live gathering now. And the topics and conversations and courageous and necessary things we've dug into are really almost impossible to believe. And we keep doing it in more real and important ways. So we are truly honored to have you with us. On December 1st, we celebrated World AIDS Day. And so this session has to be about the humans and the human experience of living through the HIV and the AIDS epidemic, and what lessons and things were learned in that time that can get us through and will be a part of the future after the COVID-19 pandemic. In preparing with our panelists, who you'll meet in just a moment, this is my first time really exploring and learning deeply firsthand from the people who changed our world at that time. And Luis, you said in our opening comments, you didn't know you were changing the world. You were just trying to stay alive. And I can't think of a more powerful way to introduce the significance of this topic and how much the three of you are heroes to modern day advocacy. And so truly this will be an important conversation. And then we'll have time to interact, and we'll end before today, the close of today, hearing from our working group leaders, the journeys that our working groups have been on over the course of this program, the things we're hearing and learning, and get your input as we go into 2022 to continue to make this even more meaningful. The last thing I want to share before I welcome our first speaker, Neil Bertelsen, is my personal experience and why this is so important to me. And that is in the 80s and early 90s, when I was becoming a teenager, I was watching the HIV and AIDS epidemic from the sidelines. And I was a part of hearing the blame and the negativity and all of the things that in many ways defined what that time became. And I've spent most of my adult life unlearning what I thought I knew as a teenager. And so to have these conversations and hear from the people who are making our world better because of it is an incredible, humbling honor. And so, Neil, I can't think of a better way to introduce my friend and hero, Neil Bertelsen. Neil, please.
Thank you very much, Dave. And let's start I will start by talking about some personal experiences. And like Dave, my first personal experience started long before I knew anyone or was personally touched by HIV. I experienced, first of all, how society reacted to HIV. And I have to tell you, it was not a pretty sight. What followed was, growing up into a young man in the shadow of an epidemic, but within a society that was so negative, so fearful, and so full of loathing. And I'll just put in the chat here, if I can, some of the newspaper headlines I remember from the time. Oh, I don't think that I can do that, sorry. Does anybody know, do I just put this into the chat box? I will leave that, I'll share that with you later. Okay, but what these headlines would show you, and you'll see them later, is the kinds of headlines that I grew up with as a young man. I'd shoot my son up if he had AIDS, said the vicar. Gay virus plague, my doomed gay plague. Those were the kinds of language that was used in mainstream popular media during the 80s in Britain. This was also the time of Margaret Thatcher. She ruled Britain during that time, and she cut a new law called Clause 28, which prohibited any positive communication about gay life or gay people in most circumstances. It was illegal. So this forced many gay support groups to close down. There could be no positive debate. And it was within this environment that the virus landed. And it wasn't really until the 1990s that things started to turn around. And I remember that time really well. There were still no effective treatments for HIV. The first drugs had come out, but they didn't really work very well. We didn't know how to use them properly then. So it was a roller coaster of hopes and disappointments. And for me personally, it was in the mid-90s that things turned around for me. I became editor of a magazine called Positive Times. It was a recently new magazine, and it was the first national magazine in the UK for people with HIV. And suddenly I had the opportunity to be a spokesperson for the community. I was never at this point a member of a patient group, but I did now have a voice and I was determined to use it. And I have to tell you, when I took over as editor of that magazine, the issue before I took over, the main articles were about how to choose your coffin and how to write your will. And I looked at that and I thought, in no way is that how I or any of the people around me feel. We have to be empowering. We have to be positive. We have to find ways of getting through this together. And so I was determined to change that. And so my editorial every month, I would explore my personal reflections in a positive way. I wrote articles about real people and real stories and taught the country so that you could give voice to people who had no voice, to tell their own stories and share their own experiences. I'd even use old-fashioned photo stories to highlight key medical and social dilemmas, so we could really explain scientific concepts in a way that people could pick up and use and take to their doctors. And it worked. People would stop me on the street and tell me how much this particular article had helped them have a discussion with their doctor or with their partner. And I have to say, this was the best job. To this day, this was the best job I ever had. But if I was to explain to you why it's so positive for me, I think you'd think that I was a bit crazy. But one of the best parts of my job was when I visited people in the various HIV hospices. And yes, these were people who were often days from death. And yes, these were people who had been abandoned by their families, by their partners, by their friends. Some had been evicted from their homes. Many had lost their jobs. But what I remember is not the complaints or the despair. I heard very little of that. What I remember is laughter. I remember sitting on the end of somebody's bed and we're both laughing until we cried. And that's what I will always remember about that time. Thank you.
Jim, the more I get to know you, Neil, the more I get to know you, the more I respect you. I could see, Luis, on your face, the empathy and understanding as Neil was talking. I can't wait for our attendees to meet you now. Please, everybody, welcome Luis Binder.
Thank you so much. Well, if Neil felt out of the picture, imagine how women with HIV felt at that time, because we were told women couldn't get HIV, which left me in a rather odd position since I had it. But I went to my doctor for almost 6 or 7 years with complaints, mainly gastrointestinal complaints, but complaints that were clearly immune-based. And she had me having everything from gastritis to mental health problems. Well, maybe I do have those, but they weren't the cause of this. And finally, it wasn't until 6 years later that I finally convinced her to allow me to have an HIV test. And she didn't even want to give it to me. She said, your chances of having HIV are less than 2%. And I said, yeah, well, that's enough for me. It turned out it was a positive test, which she phoned to give me, which you can imagine, it was a death sentence at that time because it was 1994 and we had no drugs. So I knew she'd just phoned to tell me I was about to die. And then she said, don't cry. That was my favorite, don't cry. And she never wanted to see me again. So I ran down to her office and I said, no, this is not going to go, at least to get me to a specialist. And so she did. She would have done anything to get rid of me. And so she did. I was told I had about 2 years to live at that point. And like Neil, I was taught how to make a will and, join bereavement classes and all that sort of stuff. But I decided to do everything I could to learn about this disease and to learn about what was coming down the road, hopefully, in terms of treatments. I was fortunate enough to find a doctor in New York City who, ironically, was a Canadian, is a Canadian, hope he's still there, is a Canadian, and he was doing HIV research. And I went to visit him a few times, and he helped me stay alive for the 2 years that I needed to until 96 when drugs came along. And he also told me which of the new drugs that were being researched was going to be the most effective, because he was looking at all of them. And he said, hang in for those. So I did. I recall spending my own money to buy 3 months supply of those drugs in the United States because we didn't have them in Canada. And they were a miracle. They were truly a miracle. Within weeks, I was just back to being, alive. So I always believe in lessons from personal experiences. So here are my lessons. Number one, things change. So even if your doctor tells you today that you have 2 years to live or any number of years to live, that may well be true based on what they know at that time, but things change. So please don't give up hope, because things could change for you. That doesn't mean don't be realistic and, don't do preparations, but don't give up either. Number two, access to what we call in Canada social determinants of health. That is money, housing, food are very important to survival. And we must really, really remember that. I mean, I had the money to fly to New York City and go to visit this doctor. Most people in Canada did not. Luckily, I brought back all my learnings and shared them. And we have a responsibility to do that. Number three, clinical trials are very important, but be careful before you join one. Really learn about them. There are clinical trials and clinical trials. So think very hard about that before you do. And four, approvals for drugs can sometimes be far too slow. And so what in Canada, what we did was start a national organization. I was one of the co-founders that fought for nothing but that. Get these drugs into this country. And on February 7th of 2012 will be the 25th anniversary of the founding of that organization. And a gang of us survivors who started that organization are going to have a virtual party to celebrate the 25th anniversary.
Louise, congratulations. That's amazing. It's been such an honor to meet you through this process, and I'm so excited for the rest of the conversation today. Our third speaker is someone that I met almost immediately when I became an advocate in 2012. Jim Howley, we are honored to welcome you. Please, everybody, welcome Jim.
Hey, Dave. Hello, everybody. So good to be part of this. I've loved watching this. I can't believe it's been 28 shows. My gosh. And Dave, you look even younger now. Wow. Hey, I don't know where to go, because I think Neil and Louise really filled in so much of the important story. I'd love to share a little bit about what I experienced, and then just to really look at how advocacy has really saved my life. There's absolutely no doubt it saved my life. But, as Neil said, I was living out in LA at the time, so a little bit different. Rhetorically, people were okay with, the gay lifestyle. But when it came down to it and AIDS hit, the gay plague, as it was called back then, there was no name for it. There were 10 cities in West Hollywood. And people probably don't remember that. When I talk to them today, they don't remember that. People were thrown out of their homes. People were thrown out of their jobs. Their families were turning their backs. And I'm not trying to say anything political, but I scoff when people laugh and say, I have rights. I don't want to do this. I don't want to do that today. We didn't have any rights at all. In fact, we met with C. Everett Koop as a group of advocates years later, and before he died, and he told us the terrible things the government was planning on possibly doing. They didn't have the power to do it, thank goodness. But that's pretty scary, So we didn't have much, but what we did have was we had each other. And prior to HIV, a lot of people again don't remember that. This is just from being so old. The gay and lesbian community did not really work well together. Men couldn't go to a women's bar, women couldn't get to a men's bar. It was just the way it was, two separate worlds. But when it came to HIV, the women and the lesbians came together to fight for their gay brothers and the people that were really being affected at that time. And sure, it's affected everybody now, but that was just that microcosm of time. And to watch the way people came together, and my first march on Washington, I was actually with ACT UP Philadelphia, marching on Washington. The thing that got me was a group called PFLAG, which is the Parents and Family of Lesbians and Gays. I never knew that gay people my age, especially with HIV, could be accepted by their parents. And here were older parents pushing their sons who were about ready to die in this march on Washington. That really hit home, that I had nothing to be afraid of. And I'll tell you, I reached out to my mom, who was a nurse at Atlantic City Medical Center. She immediately took me under her wing and tried everything she could. And at that time, she told me nurses wouldn't even touch people with HIV. Not everybody, but a lot of nurses in Atlantic City would not touch people with HIV. And I got to tell you, Atlantic City was devastated. Every single person I know from there has passed away. So, I think, again, filling in the gaps of the story, the clinical trials, as Louise said, they saved my life. The Buyers Club, they saved my life. And to show you how far I've personally come now working in industry, I remember getting my first packet of drugs that were unlabeled from the Buyers Club out of Fort Lauderdale. So that movie Houston Buyers Club is very accurate. And it said something about being toxic. I didn't even know what toxic meant. So I wrote a note that I took this drug if I pass away. I laid on the bed in my little apartment. I put the note beside me and I took these drugs. That's how naive I was, but how scared I was that I knew if I didn't do something, I was going to die. I bought my suit to be buried in. I still have the suit. I don't fit anymore by far. I'd love to, but I still have that suit. I picked my music and I was 25 years old. How right is that? It's just not. But luckily, with industry, with advocacy, with everybody pushing, as Louise said, drugs don't get approved fast enough. How do you think we have now emergency authorization? How we have expedited reviews? That came from the push and the partnership of advocacy with industry, with agencies to get these drugs through a lot faster. And luckily in '96, I remember it so well, Louise, I was on a blinded study, again, one of the last blinded studies in a life or death situation because of the HIV advocacy. And I remember taking a sip of this liquid that was already god awful, but it was even worse. So I knew I had been on a placebo. And I jumped off the table. The doctor's name was Ellen Yetzer. I gave her the biggest hug. I said, this is the drug, because she was blinded. She didn't know either. And again, as Louise said, within weeks, I went from 2 T cells that I had for 2 years where I couldn't even drink tap water to almost healthy. It was incredible. These, were they intolerable? Yeah. Have they gotten much better? Yeah. But again, I love Louise's point. Just wait, everybody. Do your best. Research. Did I make a lot of mistakes? Yeah, I injected myself with pregnancy hormone because I was told that that was how you got rid of Kaposi sarcoma. I did some crazy stuff, but again, I was a desperate man, ready to unfortunately pass away. So advocacy has saved my life. I hope we can continue to work together to help everybody, maybe not save everybody's life as drastically, but have a wonderful quality of life with what you can have with your caretakers, with your family, with your loved ones. I think that's where we are today. So I know I rambled. I'm sorry, Dave.
Oh my God. My gosh, Jim, I saw Kathy in the chat talk about your stories. These stories are why this is so important, why this matters. And I can't think of a more authentic and vulnerable way to start. So thank you all three of you for starting that reel with this. Neil, if we could start the conversation with you. And I have to apologize. I called you Jim. I was so lost in your story that I mistakenly called you Jim. So I hope you two are still.
I answer to everything, so don't worry.
I love it. Thank you. So, Neil, in that time, and we have speakers here from Europe, Canada, and the US, what was that time really like in terms of not being heard and facing the stigmas and trying to fight for change? What was it like to do what you did through that time?
You had no choice, if I'm honest with you, Dave. It was either that or lay down and die, as Jim said, you know, and Louise has also mentioned. You know, it was either we came together as a community or we fell apart. And strangely, the fact that we got so much stigma on the streets strengthened us. It showed us that, especially in those early days and that early decade, that there wasn't somebody going to charge in and save us, and somebody who's going to be so lovely and nice and come up with the answers. So we had to come up with the answers ourselves. And I think what developed during that time is something that we've lost over the years, actually, was this grassroots sense of community that was very physical. So very, you know, we had drop-in centers in most cities, and drop-in centers was like being in a living room, but it was in a living room where everybody in that living room had HIV. It was where you'd learn and discuss the latest scientific advances. It's where you'd share rumors about what was coming down the line and what was not coming down the line. The fax machines would be going because people in San Francisco would know about some study results that we hadn't heard of yet, and they would fax it through. Before the internet, most of this happened. So that's worth just reminding people that there was life before the internet. And so the stigma was intense, especially in that first decade and a half. It got better over time, but only slowly. And that meant that the community itself, they had to come up with their own solutions, their own way of communicating, their own communication channels, their own fax networks. They had to develop everything from scratch and use it. And it was also, I think, was the first example of truly international advocacy around that time as well, because you didn't have all the answers in any one country, not even in the US, all the answers weren't there. So it was this network that started to build around the globe that allowed information to be shared in ways that was unheard of at those times. And I think that really helped us a lot. So yes, it was tough. A lot of people lost their jobs. I mentioned before, a lot of people got evicted. It's quite common for families to completely disown their children if they found out they had HIV. They'd lose their partners, they'd lose their friends. You know, this idea that the gay community was all lovey-dovey together, that wasn't really what happened in some cases. Some people would announce that they had HIV and all of their friends would scatter. So they were left with dealing with a diagnosis and having no support network around them. And that's why these drop-in centers, these physical places people could go, were so important.
Wow. Luis, I know you and I've met you as this advocate that you are today. And knowing Neil, I did it again, and getting to know more of how you've grown and to become who you are today. Luis, what was that like for you starting in that place with those experiences?
Well, I mean, first of all, I was terrified. I was young-ish and certainly being told I was going to die in 2 years was not in my plans. And so the first thing, oh, sorry, a little water. I'm just getting over a cold. So forgive me for that. So the first thing was to get over the terror. And so I started by getting a social psychologist who helped me psychologically to deal with what I thought was the last 2 years of my life. And interestingly enough, I thought to myself, you've done a lot in your life. You've gone to school, you've had a good job, you've experienced a lot. What is it you think you haven't done? When you're lying on that bed, dying in 2 years, what is it that you haven't done? And what I felt I hadn't done was give enough back to the world. So honestly, and so I decided, okay, well, if it's the last 2 years, I got to do this. So I learned as much as I could. I got involved. Peer support, Neil, your point about peer support, absolutely important. We supported each other, and we were, and Jim, your point about laughter, we were so heretical. I mean, I remember, I can just give one joke. A friend called me, said, oh, one of my other HIV positive friends is really sick, and he's asked me to go and help him. And I told him, sure, as long as I can only, but all I can do is make you food that I can slide under the door. So I guess you'll be eating a lot of pizzas, and these were the kinds of crazy things we said to each other. And it kept us going. The laughter kept us going. There was so much more of it than anybody can imagine. And I also believe, Jim, that HIV saved my life. In fact, I personally think it's saving me from COVID, but I have no scientific proof of that. I've just decided to believe it. So I'm gonna believe it. And I was also angry. Anger kept me going too. I was angry at people. I was angry at my husband who had infected me and who knew he had HIV and did not tell me. I was angry at people who discriminated against me for being sick. Like, hello? Like, blame the sick person. And I was angry at people who were too stupid to learn about how this disease was transmitted. And to your points earlier, Neil and Jim, people be scattering. When they were scarier to me than I ever could be to them. I didn't, they could give me a cold. I wasn't going to kill them with a cold, but they might kill me with one. So I was, and the third thing I was grateful. I was so grateful to the HIV community that came together, and they accepted me as a straight woman amongst lesbians, gay men, and drug users, and we were quite the little assortment, weren't we? I'm still very good friends with George Carter, who ran the Buyers Club in New York City. I don't know if you know George. Now talk about heretical. Sorry, George. But I love him to bits. And again, lessons. I always want lessons. So do not internalize other people's biases. Don't believe anything they say. And for the cancer people, one of the tragedies I hear is all this business about, oh, lung cancer, well, you smoke. Well, people smoke because a whole industry addicted them to cigarettes. And that's not their fault. And we still sell them legally. So get over it, people. Don't internalize any of that madness. Secondly, find your own community of support. Get psychological support. I certainly needed it. And learn facts and educate the people around you.
Thank you. So powerful. Jim, I think of you as a champion for voice, like Louise was just talking about. What was it like in that time when you were trying to find your voice?
Well, it was a growing, I think it was like Louise was saying, there was a growth to it. Again, I'm in my 20s. I was still so young. I didn't know what any of these terms were. I certainly wasn't expecting to be ill, finding the right doctor. But what I started doing at that point, when I started really getting ill on paper, was I was living in a smaller town north of LA, Santa Barbara. And my friends around me were dying. But in Santa Barbara at the time, it's going to sound terrible, a lot of people were getting assisted suicide. So this is not a Jack Kevorkian thing. This was happening very readily in HIV because they thought there was no hope, and they didn't want to go so far that they would be, so ill that they knew there was no end. So there was assisted suicide or a lot of suicide. In LA, it wasn't like that. There was a little more hope because it was a big city, a lot more people, a lot more specialists. So I would drive, it was 90 minutes to and from every single week. We went to the doctor back then for blood work. That's how ill we were. But I would try to drag my friends down there and they would not go. And that was where my voice was. I was afraid to be pushing, but yet my friends were dying. So there was a certain point I said, that's it. I am going to be as pushy as I have to try to save lives. I wasn't very successful because people were doing what they were going to do. But that was the voice I wanted, where I was going to say, please, everybody, read, go to specialists, stop dying, do anything you can. There is going to be a cure sooner than later. But it took a long time for me to get that voice. And now it's there and it's louder than ever.
Yeah, so powerful, Jim. Neil, that connects so much to what I hear you say a lot, is that, somehow we weight people's voices differently, or there's perceived weight to voice. And I've heard you say that whether somebody is 3 days or 3 decades into their experience, that experience is what matters. That's your life and your humanity. What are the lessons that we can take from you finding your voice to create sustained change, and all the things you're doing now around, voice and changing the future?
It's interesting, isn't it? Because I think voice is about confidence. And first of all, as Jim said, it's like you're not that confident. You're scared of becoming too pushy, or certainly in Britain, we're very polite. We're not going to shout at anybody, And so it takes a while for that confidence to build, and it's knowledge that builds the confidence. If there's one thing, I think the really key lesson here, when I think back to that time, is this was a very unusual situation where we were learning at the same speed as the clinicians were learning. And so we had as much knowledge as the clinicians had. We had as much knowledge often as the regulators and others in healthcare systems had. And when we started to realize that the whole power structure starts to break down, then your voice suddenly, you have more confidence in your voice. And so that leads to the kinds of one-to-one discussions you can have with your doctor, because you're talking about the latest scientific papers together, but it also leads to what you can do as a community together, because you have the knowledge not just of the disease and the science, but you have the intimate knowledge of how it's affecting the community. So you see the social impacts as well as the clinical outcome impacts of what's happening. And that sounds very technical, but actually pulling those two worlds together is, I think, what made HIV advocacy very powerful. It was able to link quite really tightly the clinical effects that HIV was causing onto these social determinants and stigma and those kinds of issues. And through that, to change the way that people looked at disease and thought about diseases in a much more holistic way. And I just want to reflect as well on something that Louise said. She talked about cigarettes. If I'm in a room with HIV advocates, you can bet that they're nearly all smokers, still to this day, and that tells you something. It tells you something about, why is it that people with HIV, a lot of people with HIV, tend to remain smokers? There's something there about how they feel about their health and their place in society and what they have gone through. And I think that's a really interesting way of looking at this, that these experiences that we're all talking about today, they change how you feel about yourself. Some for good, so this confidence in speaking out and being public, but some for the bad. You feel bad about yourself. You feel bad about the journey that you've gone through. And so I think there's lots of elements in there that relate to modern advocacy as well. And I just want to briefly just pick up on something that has been mentioned in the chat from Carol Deep, and really talking about this link between COVID and HIV. People forget about this now, but HIV, there was a group of people with HIV who refused to believe that HIV existed. So they were virus deniers right back then. They believed that the symptoms of AIDS were caused by the emerging HIV drugs, and that HIV itself had been invented by governments and societies. And then you see that that's happened again, this time with COVID. And so there's part of me that thinks that we've lost a lot of the lessons, a lot of the knowledge that we had in the past. We've somehow thrown that out the window over the last few decades, and that's a shame.
Neil, trying to connect dots inside something I've experienced through this together. And Luis, I think you described it so well. You talk about inside versus outside. And, I've been a patient insights and patient experience researcher my whole career, trying to learn the experience so we can make improvements. And I've also been a cancer patient and cancer caregiver, and I try to live in both of those minds, but I've never had the clarity that you're having now collectively around this conversation. Luis, can you share what you were talking about with the being inside versus outside of advocacy?
Yes, well, we were outsiders to everybody. And Neil, to your point about how much we've lost, I think the reality is nobody ever wanted to learn from us. We were always open. I was open to share with cancer patients 25 years ago what I knew, and they just didn't want anything to do with me. Now, we must remember that, like people in Britain, Canadians are polite, not something I'm always called. In fact, people have often said to me, "Are you really an American?" And I take that as a great compliment, by the way. Yeah, you cannot be too polite. And we knocked on the doors. We kept begging to be invited in to policy tables and policy decisions. And I'm not so sure anymore that that's exactly great. I think we need to continue to have a continuum. We need to have people knocking on the door outside who don't want to come inside. Because what I have experienced in the cancer field that I'm working in now is that they invite us in and then they don't listen to anything we say, but they can check it off that they, well, we asked them, but we didn't listen to anything, but we asked them. And so you want people inside, but in my view, you want them inside more to tell the outsiders what the insiders are doing, so that you can respond from the outside. I'm not at all convinced that being inside it has proved to be as successful as we hoped it would be, because it's tokenistic, in my view, for the most part. They don't understand that life experience is an expertise of its own and deserves the same respect as all of their PhDs and every other blah blah that they've got after their names. So this is a very big dilemma for us, I think.
Yeah. Luis, something our working groups in this platform talk about all the time is focusing on where we want to make change happen, right? Not sort of where is our place to make a difference. And I hope our working group leaders will share that when they get to share their journey shortly. But you're hitting on exactly what we talk about, which is, where do I fit? Where is my change focused? So really powerful. Jim, what about for you?
Dave, repeat. I'm just enjoying everything that's said. I'm reading the chat. Repeat again what the overall question, because I loved everything you just said. I'm sorry.
How do you sustain change? How have you gotten to this point and really understood your place in advocacy in the world of change now today?
Well, I think about this, especially because I did choose to go inside industry after being very radical on the other side, seeing it just that it was an us and them. Then when I realized I became part of the community, which is industry, and I firmly believe that industry and advocacy want the exact same thing. I've said this 1,000 times in my career, both as an advocate and now in advocacy. We just talk differently. And as Louise said, I love what she said, because as I'm getting older, I experience ageism a lot, because I think I'm getting so darn old. But, our experience is probably different than the industry scientist experience, but are they equally important? Absolutely. There was something, just a real quick anecdote. I think it was the Australian advocates, very good advocates in HIV, amazing. They started seeing this thing we were calling lipoatrophy, which is a lot of us on the earlier medications, we're losing facial fat, we're getting humps on our back. It was redistributing fat unnaturally. And the doctors and the scientists really weren't seeing this because they were looking at kill the bug, undetectable. They weren't seeing these life-altering, and again, you're talking about younger people, so they're really seeing these things changing in their friends and everything. And I remember advocates hammering on industry stores saying, what are your drugs doing to our people? And our chief scientist at the time, I'm not going to mention his name, great guy, he was in front of all of us, he said, does every GD, one of our clinical trials, include these drugs that look like it's going to cause it? They didn't know. But thank goodness the advocates brought it to their attention. So I think we have to learn that we are symbiotic. You know, as much as we don't want to think that we are, we need each other. And I think if we could learn a way to talk even more productively than we do today, and I think we've come miles, we don't need to be screaming and shouting and this. Sometimes we do, you know, and sometimes we will moving forward. Everybody might. But if we can learn to be that, to figure out how we fit together and how we work together, I think it's going to be the best outcome for patients. So I think, as Louise said, it's a continuum. We need to keep moving past that continuum and not go back to the way things were.
Yeah. Jim, what I heard you say was the co-creation process for system and sustained change. Things this big, it's the only way is to co-create, right? I started as a cancer advocate, and being a part of this program, the Advocacy Exchange, with all these different disease areas, including the humanity, I've learned more in the last 18 months than I did just as a cancer advocate, because it's about humanity. So what you said is so beautiful and true. In our last 7 or 8 minutes, as we're wrapping up the panel before our working group leaders share, Neil, your life is committed to system level change. And when I think about the work that you do, it's to create sustainable systemic change. How are you doing that? And you're also leading one of these working groups, so you're doing it with us. What is that like for you to be on the front lines?
So it's just an extension of those experiences we talked about before. You know, that's where it all comes from. So system change, you know, building on what Louise and Jim have just said, system change comes by understanding the system, understanding how to navigate that system, understanding who's important within that system. Sometimes, as Louise says, you need the outside shouting to get them to open that door, to let you in. But if you look at what happened with the FDA in America during the HIV crisis, there was a lot of shouting outside. This is not good enough. Things have to be faster. What was happening behind the scenes was quite interesting, because a lot of it was out of sight. It didn't have the media attention that the big demonstrations had, but it was the advocacy community really teaching themselves how drug regulations worked and understanding why the FDA were demanding what the FDA were demanding and why that was inappropriate. And so being able to open up those discussions at the system level, so that's the inside thing, but you know, Louise was saying, no, that doesn't always work, and I agree, it doesn't always work. But that knowledge about how systems work and being at eye level with the system makers and the system rulers, if you like. We're not less than them. We have experience, knowledge that is just as important as all of the other experience and knowledge that they have from the clinical trials and various other bits of data that they have. And it's going in there on that level, eye level, that's the same, and saying, this is not good enough. Here's a way that it could be better. So where I think shouting doesn't work is when you're shouting against something, but you have no solutions yourself. They have to be credible solutions that show you understand the limits of the system you're trying to change. It's no good asking for the moon. The moon's never going to be available. You have to find a way to get there.
I love it. Neil, you're going to be back to give us an overview of the journey of the patient voice and patient-focused drug development. So Neil, you're going to come back in just a couple of minutes. Louise, for closing thoughts and tying all this together, what is, I think of all the relationships in people's lives you've influenced, what is system and sustained change for you?
You know, Neil, to your point, one thing I think that we had actually to our advantage was the fact that researchers, policymakers, and medical people knew that we knew that the emperor had no clothes. Nobody knew anything. So they couldn't sit across the desks, as I sometimes see the cancer doctors do, with all due respect to them, and tell us that they know what we should be taking and not taking and doing and not doing, because they knew that we knew they didn't. And frankly, let's be honest, doctors don't know. They do everything by a process of elimination. And that's how it works. And I respect them, and I work with them, and I work with the researchers. But just because we have a few drugs in cancer, for instance, doesn't mean they really know as much as they pretend to. And I wish they'd be more candid about that. And then we could be real partners in solution making. And that's profoundly important. So I believe in policy change. I've spent more than 25 years working at it, so I better believe in it. It does not mean that individual day-to-day work, the way the AIDS service organizations did and still do help people individually, isn't profoundly important. But policy change is also profoundly important. So we need to learn to understand policy and to have, and I agree entirely with you, Neil. I truly don't ever go in without some kind of solutions. Sometimes they aren't the right ones, but at least I'm trying. And I think that that's very important.
Yeah. Louise, you gave some incredibly beautiful advice in the beginning. I heard don't give up and you don't know what's coming. To me, that resonates. And I hope people who are with us live will share this session. It's on the platform as well as all the others. I'm excited for everybody else that'll get to watch this and hear your words. So thank you, Louise, so much. Jim, your closing thoughts before we go to our working groups. What is sustained change and co-creating the future for you?
You know, I think it's realizing that, you know, the same old thing from 20 years ago doesn't work. You know, we have evolved, both advocacy community and industry, as have hopefully physicians and doctors, et cetera, HCPs. We have a voice that needs to be included as patients. That voice needs to not only be at our doctor's office, but within industry. I think sustainable change is making sure that there's a systemic way to include the patient voice in clinical trials, in drug development. You know, also, as Louise was just saying about policy, I remember so well being at Sacramento. I went to do something around HIV, and I did it so many times I can't remember anymore. And the politician looked at me in full earnest and says, you know, I understand your story, but as soon as you leave the room, somebody is going to walk in with colon cancer and have an equally important story. And I think that really hit me, where industry and advocacy can come together to teach each other. How does industry drive access? How do advocates drive access? How can we work together? You know, and use the language that these politicians might understand. Is it a sympathetic, empathetic story that we're telling? Absolutely. But how can we also add to that some data, add some health economics, et cetera? So when we walk in there with our empathetic story, we've got the whole package. And boy, we're not only at eye level, sometimes we're sitting above them. And that's where we need to be.
Powerful, Jim and Neil and Louise. Thank you for bringing the humanity and the vulnerability to this. I knew it was going to be a powerful conversation before we had it, and I can't imagine it being more powerful than you made it. So truly, with all of our hearts, thank you. Neil, if I can ask you to stick with us, and Louise and Jim, please as well. We're going to turn to our working group leaders now, and Sheila, if we can start with you to share the journey that your group has been on. And I encourage everybody, many of you have been in Sheila and the others groups, please jump in and use the chat function, or if you want to raise your hand to add comments, we'll try to keep this interactive. So Sheila, please, over to you.
Thank you so much, David. And thank you very much, Louise and Jim and Neil. Brought back memories, good and bad. And it certainly was inspiring to hear your stories. I think as you were speaking, I thought about the watershed moment that we were in with HIV, the fact that things were changing and they never went back the same. And we currently are in another watershed moment with COVID-19, unique historical change that's never going to go back the way it was before. You hear so much talk about we want to go back to normal. I'm not quite sure I know what that is. So when I was invited to be a part of this platform, it was clearly an opportunity for me to share my journey with others who had just begun their advocacy journey and to see, as David said, where they would fit in. My topic is racial and ethnic health and healthcare disparities. Obviously, COVID-19 glaringly illuminated those disparities, and it really brought to the fore the fact that there are still people in this country who suffer disproportionately from the inequities and injustices in society as a whole. So my group, made up of people who were living with chronic disease and life-threatening disease, as well as who were with organizations who were dealing with looking at those disparities. The data are overwhelming about why people in this country who are insured, middle class, educated, are still dying sooner, suffering more, and getting sick younger. So the first few sessions of my working group was really a time for these people who were in this space for a long time to share their stories. We had to listen to the emotional, gut-wrenching experiences that many of them had with being diagnosed, getting into treatment, and living with the disease, and some surviving with it. But those stories thrust them into an advocacy mentality. And that's why they were there, because their personal stories were so impactful. They said, we don't want anybody else to go what we went through. So how do we help those patients and those providers who were so committed? So those first two sessions were listening to lived experiences and those stories that really thrust the person into the right mindset and heart set that we were trying to address. But because race is so intricately involved in when you get care, who you get care from, how you get care, that was an overriding part of the conversation. I can't change what I look like and where I come from and what I speak like. So how do I engage a system that doesn't really treat me well, hasn't treated me well historically, and certainly from a contemporary perspective? So we explored all of those feelings because we needed to put them into a place where patients, advocates would feel empowered to really get into the system while hopefully at the same time trying to change the system. And that's a daunting proposition. And where do you fit in? And I think most of the people in the group that expressed their desire to change had to really think, well, where do I fit in? If I've just begun being an advocate, do I just march on Washington or my state capital? Or do I keep it in the community and help people who look like me, who have the same condition or disease? It's a constant juggling act that you have to select. Most people in my group share that they do both. They do both. But now it's a matter of focus and being intentional because the systemic issues are so daunting and many times they're discouraging. And so many in this group that I had the privilege of facilitating and talking with are now aware of those social determinants that Louise spoke about, that Neil spoke about, that are more determining outcomes and quality than whether you have that insurance card. Housing, public safety, education, food, all of those things have to really be put into the mix. And I see that happening, but pharmaceutical companies and other healthcare organizations have to learn how to partner. And that came out of my group discussion. You've got to have the unusual suspects at the table so that you can modify factors that can be while still being aware of the systemic issues that we're all struggling and grappling with. So it's been a very emotional experience with my group because they all want change. It's not a 90-day wonder, it is a journey. And we've got to really be committed to that journey while taking care of self to make sure that it all is going to work for everybody. And I always say it's going to take each one of us to make a difference for all of us. So what does it mean to be an advocate in whatever level you are? And how can you sustain that feeling, that passion, and put it in a realistic context for change? So that's kind of where we ended up in our last session. What are the guidelines? You know, what does it mean to be a quote unquote good advocate? You know, what are the tools? What are the skills that you need? How have you continued to educate yourself so that you have your information top of mind? And so it goes from the emotional to the data-driven, so that we have a realistic basis, an evidence-based strategy to include people who don't have a voice.
Sheila, having been able to attend so many of your sessions, I have a notebook of your wisdom that I refer to oftenly. And one of the many things you said that has changed my perspective is that when someone joins advocacy or whatever their change is, they don't know the systems in place that are preventing real change. And
Exactly.
I've tried to bring that into my own perspectives and understanding to be more open. And fortunately for you and all the working group leaders, your journeys are all part of this program. And I see Katie put the link. So Sheila, all of your session summaries and notes and things, if somebody becomes an advocate next year, they can go back and watch all those. So they have been profound.
Well, I'm humbled by that, David. And again, it's you just kind of take it one day at a time. And eat this elephant. So, and looking at Louise and Jim and Neil, they've made monumental steps in this mindset, the heart set, which is what I love so much about Grid Health. Your humanity is what fuels your action, and that action then becomes realistic and achievable. And that's what we have to keep. We have to keep moving forward. We've got to keep doing this. We'll get it right eventually.
I believe that too. So we're the end part of this conversation is interactive, Sheila. So we'll come back for some questions and thoughts for next year too. So we'll be back for some more. If we can, Brad, I believe Brad is with us, and fresh off of a flight, he was able to join us. Brad, what is the journey of your group, which is an equity group focused on access to care?
Absolutely, thank you. And Sheila, thank you for being one of our graduate instructors in advocacy. We all learn a lot from you and appreciate your wisdom. The group that I've been working with overlaps a little bit with Sheila's in that focus on equity, but we have been looking more about systemic and policy things, including, for example, one of the large points being about the way that economic systems of healthcare, whether that's private insurance or public insurance, influence who has access and when. And where we have arrived to start with the conclusion is much like Sheila's group, recognizing that so much of the work in this space does not start from the patient voice. We've been aggregating what's been done about best practices in healthcare and best practices in insurance systems and policymakers and things like this. And they start from interviews with policymakers, not the people. So as our panelists have also been sharing, of course, throughout the day, the starting point has to be the voice of that experience and expertise to lift it up. And so that's the path forward for my group, is more advocate, more human voices, so that we can question and improve and ultimately arrive at a place where the best practices come from the people who are most affected and the people whose lived experience helps them know best about how to improve equity and access.
Boy, Brad, if I ever heard a call to action or an opportunity, that's where we go next as a group, right? Is to validate these things we've heard more broadly. So I think you framed that beautifully. Thank you, Brad. Neil, if we can come right back to you. I know you have done exactly what Brad said. You started with these industry principles and best practices to really define what it means from advocate perspectives. What has that journey been like?
I think it reflects actually both what Sheila and Brad were saying, actually a lot of similarities there, which is great because it's showing us that there are common areas of need that we can work on together going forward, which I think is fantastic. When we started the journey, we know, some of us know that those people who develop medicines are starting to speak to patients more. We hear about it, we read about it. And we started that discussion, well, who's involved with that? Is anybody in this group at the beginning? Were they actually part of those discussions? And a few people were, but most people weren't. And what became really clear at the beginning of the journey, that even this concept that we started to think has become normalized, which is patient involvement leading into better designed medicines, better designed clinical trials, while that's being talked about a lot, the experience from the advocacy community is that it might be happening, but I don't see it. And that's really where we started the journey off, was really this recognition that while there's a lot of noise around this, there's a lot of guidance that's out there, the actual experience is very patchy. So we started a discussion really about, well, what is the problem here? Why are medicine developers going to a few people but not going more widely? Is it, is it a mechanical problem, or is it just because they don't know everybody? What is it that's driving this? So we started to look at all of the ways that patient engagement could be more open. So what would be the principles behind a more open way of engaging with the patient community? And when I think about this from a sort of an emotional point of view, what I sensed at the beginning of this journey was a sense of unfairness. So people were saying, I hear so-and-so gets invited to these things all the time, and they're able to input their views into multiple different medicine development programs, but I've never been asked once. So there's this real sense of unfairness, and that unfairness crossed a lot of the issues that Sheila was bringing up, actually. We were talking about racial diversity, gender diversity, country diversity. Are we getting different kinds of health system patient experience represented in these discussions as well? And so what we did in the end was we said, is it possible to develop a set of key principles to aim towards? So not necessarily things that we could say, okay, we can do that tomorrow, but things that give us a goal to aim towards, that we can start that journey and accelerate that journey so we get to that goal much quicker. And there was 5 areas we thought, and the group thought we should really focus on. Making sure that when there is patient engagement, patient involvement processes, they're open and inclusive. So that we're not just inviting people, and if you're one of the lucky ones, you get invited, but there's an open and inclusive system of engaging with patient advocates. That this should always represent the diversity of the patient population that's affected by whatever this medicine is. That every side, not just the patient organizations, we hear this a lot, that people get told as patient advocates, you need to develop a capability in this area, you need to build your skills in that area. But actually, we need other organizations, the industry, the academic research community, to also be building capabilities to be working with patients in a systematic way. We need to be sharing the inputs that are gathered. So the one thing we heard loud and clear on our in our working group is that, especially the industry, actually, they go to different industry members working in the same disease area will go to a patient group lots and lots of times and basically be asking for the same information. That's causing a capacity problem. So we need everybody to be much more open about sharing what they can, what's not proprietary information, so that we don't have to keep reinventing the wheel every time. And we need to be looking at new technology and thinking, is there a way not just to get input from patient advocates, but get input from patients? So more sort of crowdsourced approach to really understanding how patients experience their particular disease or condition and what they're looking for from potential new medicines in that area. And so we've got these principles, they're pretty much worked up. We can always fine tune the language as we go forward. But I think this is really around saying, okay, we've got these principles, we need to make sure they can fly. How do we bring in other stakeholders now and really ensure that we have a roadmap? We can build a roadmap together to get to these goals.
So powerfully said, Neil. And for everyone in the audience, if you're trying to write down what Sheila was sharing, or trying to remember what Brad said and now Neil, these are all the working group products that you and your groups have spent this year defining. Part of what we're going to be sharing is those work products shortly that capture, Neil, tons of listening right in the beginning, and then really compiling those. And now we're moving into a validation stage. So for everybody, we'll be reaching out to you to share these in written form to get your input on them. Neil, if I could ask you one more thing before we move to the Future of Advocacy group. There's been so much talk around what is advocacy, and it means different things in the part of the world or the disease area or your specific focus. Can you share your thoughts, just sort of the challenge of the word advocacy?
Yeah, it is a challenge, isn't it? Because it's a very personal thing, it's a very public thing at the same time, which I think is where some of the challenges come from. Those of us that are patient advocates, we're patient advocates because of our inbuilt passion for our experiences. So there's this personal element to advocacy where we want a better world for other people like us, or for people like our family members that have been suffering. So there's this personal drive, but at the same time, we understand that we live in a complicated world of systems. And so we start to realize that advocacy has to have this public dimension and this system dimension. And then we get all sort of caught up and confused by this. What do I mean by advocacy? I think if I was to summarize it, but this is just my thought, it is the application of personal passion towards a cause, however that's delivered. And I don't think there's a right and wrong for advocacy. I think there are some fantastic advocates out there who really love working grassroots with people with the condition, helping them every day. And there are really, really fantastic patient advocates who work at the national or the global level, working with policymakers, trying to think through how systems work. They're part of the same continuum, but they're all driven by that same personal passion.
Such a powerful transition to Gary's group. And Gary has been working on the future of advocacy. He is not with us today. He's actually in flight to the ASH conference in Atlanta. So if anybody here is going to be at ASH in Atlanta this week, many of us will be. I hope to see you in person if you're there. I have the honor of sharing on Gary's behalf the future of advocacy and where his group started. And so starting from, Brad, to your point, the patient and advocate perspective, where Gary spent a lot of the time initially was for his working group to define what advocacy means from their perspective. And through those conversations, these topics emerged sort of as the pillars. And as the Future of Advocacy working group in this Advocacy Exchange met more and more, Gary and his working group, several of you are with us now, started to move these things into areas around the care that we received and how personalized or individual it is, and the empowerment that patients or loved ones and advocates are seeking for a better future, better treatment, better care, better testing options. And then this whole issue around access, and what does access mean? Is it just access to treatment, or is it access to other things? And then awareness being around the disease and new approaches to also things like social acceptance and stigma and all the things that we've talked about. And then, of course, research to create the future, to deliver better medicines and better care. And finally, this big issue of policy and what does that mean? And so the Future of Advocacy worked through these conversations to really say, to define a future for a vision of advocacy. And this is all from Gary and his group, a systematic approach to the future so that advocacy is the norm and not the exception. Right? Neil and Sheila and Brad, to your points, don't think of us last, but how are we a part of the process from the beginning? And it embeds processes that lead to meaningful standards and best practices, which is what your groups have each been working on. And of course, uses methods that are open and inclusive to gain the diversity of input we need. And so one of our work products from this year is the Advocacy Exchange defined set of principles. And so this is something we'll be sharing with all of the audience members and members of the Advocacy Exchange overall to really look at these pillars and what they mean across activities to be patient-centered, to be holistic, to be both comprehensive and individual, and to really come from an evidence-based place. And so this is one of our many work products that we'll be sharing going into 2022 to validate these with you, the members of the Advocacy Exchange. And so with 20 minutes left, actually 19 minutes left, we want to open this up. And if I can ask the working group leaders to field any questions from the audience, you have all, as audience members, built this program, co-created it. We wanted to leave time for you to interact and ask questions. And if we can do it in two areas. The first area is, what have you gained? What has this meant to you if it's helped in some way? And secondly, what can we do in 2022 to be meaningful and create tangible change? So we will hand the mic open if you want to raise your hand or just jump on camera. It is an open floor.
Hello, this is Anne-Louise here from the BMS team. Do you hear me well? Hello. I just want to highlight incredible session, very inspirational. And what it meant to me is, well, I work with Jim on hematology area on a day-to-day basis. And it just emphasizes the importance of engaging with patient advocacy on so many levels, the systemic level, the emotional level, all these aspects that you brought up today. And yeah, I'm looking forward to continue to co-create plans with my patient advocacy colleagues. I just realized that there is so much effort that needs to go in on many dimensions, and it really requires more time and reflection than what we sometimes are doing in our everyday. So that was my reflection, and thank you for the opportunity.
Jen Serto, please, I think you were next.
Thank you. Today, the whole entire discussion, I was reminded of Albert Camus, who said, real generosity is giving everything to the future. And I just feel the first thing I want to say is just thank you all, session leaders and everyone and all the participants, just because of the level of generosity is mind blowing. Like, people don't give to an idea, they give their entire life and literally their bodies for the future of our children and my children. And so that's first. Given that we're in working groups and we are kind of creating a cadence and some relationships, I'd like to know more about my group, to build relationships with them, of course, on the platform with Grit, but also is there a way for us to know each other more collectively, maybe a LinkedIn group or something. And then I feel like I can't be 4 places at once. I feel so sad because I want to be more places at once. So I'm wondering if there's a way our community can go deeper at some point, maybe this year or the next. So thank you very much.
Jen, just a hint at one of the things that we're working towards in 2022 is separate projects to let the working groups go deeper into an area that you're passionate about. And so these working group leaders will define that and create that. And so I think it sounds like you're going to be in line for that as well. Thank you, Jen. Nancy, please.
I worked with Gary for the future of advocacy. And the one thing that it always hit home was because we had people from around the world, and what the definition of advocacy is so different depending on where you live. And so things like this hopefully will get us, and I think that will continue, that there's still differences, but I think streamlining it and helping patients understand what it is and the medical community and what the role is. But that was a very interesting part of working through things, of just what the definition of advocacy is really can vary even across, I'm in the United States, but it was an interesting thing to learn.
Nancy, as you were saying that, I just saw Kathy Traz's comment in the chat about being committed to continued listening, learning, and transparency. And listening is the first part of that, right? So,
Right.
So what was it like in those conversations where so many people had different perspectives? It's not about right or wrong, right? It's about what creates change, I think.
And it was interesting because I have a nonprofit based in Colorado. So I feel I serve cancer survivors. Am I an advocate? It's always that discussion that I have. Well, I'm not a policy advocate. I advocate every day for the survivors we come in touch with. So there's where it's a big difference that advocacy has a big umbrella of what the word means. And how do we make it simple so that it can be clear to people where they aren't confused, especially for those that are diagnosed with any disease at a time when they just need help, and to try and figure out that definition of where do I go? Because, you know, do I go here? Well, that's research. Do I go here? That's political. Do I go here? Oh, that's like us serving individuals. So it was a great discussion. It was a great discussion. I think we always, you know, came back together and lots of good points.
Nancy,
David, if I could jump in here, Nancy, you really are spot on. And we have this conversation all the time, that advocacy is a continuum. It's dynamic. It's not static. The more you learn, the more you know, your view and your role as an advocate changes. So there's no right or wrong answer. And I think that's part of why we are challenged with, you know, what is a quote unquote good advocate? It's wherever you are in the space of time. And if I can go to some industry speak, I go from molecule to market. If you don't have a thread of advocacy from the development of the compound, the chemical compound, to the treatment, to the future, I mean, you've got to be within the segment of what disease and conditions I feel are going to be impactful today. And as Louise said, it's always changing. It's always changing. So again, advocates, one of the key factors in my mind is staying abreast of the best and the brightest. If it's not best practices, it's promising practices. Where do we see the light at the end of the tunnel and go towards that light, even if we're carrying the candle? So I think we each have to figure out where we step into it and how do we take it and run with it for the whole patient, because disease does not exist in a vacuum.
Neil, I think you had your hand up.
Yeah, it was related about, it's very similar to what Sheila was saying, but really this evolution, it's not just advocacy that evolves. And I think any definition of advocacy has to allow for that evolution as well, because it does change over time. But we as individual advocates change over time. The way that I do advocacy now is very different from the way I did advocacy 20, 25 years ago. But I think patient expectations change during that time. And one of the things that I've seen really clearly with HIV, and I think Jim mentioned this, he talked about that moment where he was taking an unlabeled pill that was toxic, didn't know whether it was going to kill him or not. But he was at the stage where I'll take anything. You know, what we saw with HIV was, as medicines became available, as they started to work, then the needs of that patient community started to change, and the expectations of that patient community started to change. And we as advocates, we have to move with those changes. We can't be fighting the wars of yesterday. We have to be fighting the wars of tomorrow. And I think that's an element of advocacy as well, is that real, you know, just looking ahead and thinking, what are those issues going to be 2 years from now, 3 years from now, 4 years from now? And how do I, as an advocate, or my organization, prepare for those things?
Nancy, I was just going to ask you, as someone who's been a camper at your EPIC experience, I know how you've changed my life in helping me sort of come to terms and heal from things I didn't know I need to. May we ask you the same question? What is it like for you to be a part of these conversations?
Well, I think somebody put it in the chat. I mean, learning is incredible, right? I mean, learning about HIV and when the AIDS epidemic, I lived in Northern California, and remembering all that. And quite often when I'm out talking, people may say something about Lance Armstrong, and I say, if he didn't have cancer, we wouldn't have Livestrong, which allowed it to be okay to start talking about cancer. I believe that from the bottom of my heart. Same thing goes with AIDS and HIV, and having it come close to our family. You know, the importance of being able to talk to it and make sure people don't feel ashamed, right? As somebody said before, just because I smoked You know, we have people all the time that come to camp that are lung cancer survivors, and not one of them has smoked. And they're made to feel bad. And nobody should ever feel that way, no matter what the disease is, because nobody asks for it. No one asks for it. So being a part of this, I learned something every single time, and I'm grateful to you all, you know, for just listening to one another. I think it's an important thing to do, and we need more of it. And the pandemic made that a little bit difficult, but the creation of Zoom has helped that a bit too, to reach maybe more.
I'm closer to some people, many people now than I was before the pandemic. I agree completely.
Yeah.
Megan Claire, please.
Hey everyone. As a 5-year breast cancer warrior, I never set out to be an advocate. It happened very organically. And like the working group leaders said, a lot of us, you know, we were experiencing things that we did not want anyone else to experience. And talking about race, especially within the cancer space, it was really disappointing for me, and it was hurtful for me because I did not realize just how racism really seeps into every aspect. And that was a huge shock to me, because I really thought for sure, my gosh, I have cancer. Like, please don't look at me as like the Black cancer patient. Like, I just have cancer. And I feel what Sheila's mentioned to earlier is we get so passionate in our advocacy, but also we have to make sure that we protect ourselves too, our spirits. I've been feeling a lot of fatigue lately because of what's happening in the world, especially in the United States, and then also my own health issues, and then you know, trying to keep pushing the needle forward. So I just wanted to say that I really loved being part of these conversations and listening to others, because it sometimes makes you feel like I can take a breath, but also know that there are others that feel just as passionate, but also that this space was very safe to talk about it, because it is hard to talk about. Just because of the color of my skin doesn't mean it's easy for me to talk about. And it is traumatic every time I am talking about something. I'm just able to sometimes control my emotions. So I just felt it was important to say that, and say thank you to all of the working leaders, and then all of the, you know, advocates, and just everyone who has continued to support this initiative. It's so important.
Thank you, Megan Claire. Colin, please.
Thanks, David. You know, I just really wanted to chime in off of Megan, kind of a little bit of what you were sharing, and I shared in the chat. Just today hit home for me very much. Actually, my first real girlfriend, 2.5 years, and figuring out how to date. And I find out in the beginning of a relationship, she was diagnosed with HIV at birth. And then 6 years ago, she's diagnosed with cancer. And so I just want, you know, Megan, you kind of reiterated it to me when talking about your race and cancer, but it's amazing how when talking about advocacy, certain things can find balance in your life, right? And what I mean by that is she always felt she couldn't talk about HIV because she was too scared people were going to leave, because she felt ashamed. And when she was diagnosed with cancer, it opened her up to saying, I can talk about this. And in turn, she's able to talk about her HIV. And I think just understanding that part of advocacy is, as we've, you know, heard from David and Nancy, AKA my mom, for those of you that don't know, you know, it is listening, but it's also understanding that life can pivot, and everyone's life has those altering moments, and some open up your chance to talk about things in a different way. And so I just appreciate, you know, everyone here, the sharing perspectives, but understanding that we all have to be there to listen, and understand that, you know, everyone has that opportunity to open up about their story. We just don't know when that might arise, or the occasion that it shows up for them. So just thank you everyone for being present, but I really appreciate it today, and again, hit home.
Colin, you just inspired an idea that I think we should wrap up together with. So What you inspired in me is, if I think back to when we started the Advocacy Exchange in April of 2020, it was a core group of BMS team members and Grit Health team members and Evoke Kind team members. And the first thing we did was reach out to 75 advocacy organizations and listen. And we did a ton of listening to create the first year of the program. And now it's built to all of these advocacy groups and conversations we have like today. If I can ask everybody in the audience, if you can use the chat, what has the Advocacy Exchange brought to you, or what word would describe what you've gained? And let's end with your voices saying what you've gained. I think that is perhaps the most powerful way to end our time together for the last session this year. I would like, my word, by the way, is connected. I feel more connected to people because of this than I ever have in my life. So thank you to BMS. Thank you to the Grit Health team, the Evoke Kind team, all of the advocacy members, our working group leaders who poured your hearts and minds into this. As we wrap up for 2021, please look for some things coming for us for 2022 and how we will be a part of changing the future.